Actually, we failed to start recording from the start of the presentation. So the first three, they haven't been recorded. I'm just checking with you, team. Are you happy to present again for recording? We missed that bit because we were trying to go live and we failed, unfortunately. So if you're happy, we can try to do that today or tomorrow.
Are you
Well,
asking me now, Marwa, or in future? Or whatever you want, I'm happy.
no, go with your presentation. I'll stop sharing from here. You can start sharing.
Excellent, thank you so much. Okay, I'm sorry for the waiting. I'm sorry for the delay. I'll just um, again, I'm very sorry for the delay, but hopefully this time it's going to work. Okay, excellent. So, are you able to see my screen? Hello?
Yeah, we can see you. Just go in full screen or
Yes, will do. Excellent.
slide.
All right, so thank you so much again for attending this. So SC4 cardiology applications. Again, my name is Dr. Iham Mahdi, for whom was not joining us in the first presentation. Okay, so cardiology applications. There is no much of a difference between the cardiology application and the rest of the ST4 medical applications. The only thing you need to know is that cardiology is very competitive. You can apply for cardiology only once a year, unlike the rest of the medical specialties, and usually it's only in round one. Hi, Safa Ibrahim. Thank you so much for joining us. If you could kindly just mute your microphone, sorry. Thank you so much. Okay, so there are 9 main domains in the applications. I won't go in a lot of details because I know that my colleagues both have already discussed this, but as much as possible, I'll try to be quick. Okay, so again, it's commitment, post-graduation, postgraduate certificates. I'm sorry, let's go to the previous one. Achievements, MRCP presentations, publications, teaching, and QFP and leadership. All right, so when it comes to the commitment, I know that Marwa have already mentioned that. Unfortunately, there are a lot of differences between good and satisfactory, as you can see. Good, it means you're scoring 10. You're very committed to your specialty, and we will mention later on how to be committed to that specialty. But that means you're 100% committed to your specialty. Most probably it means that you are eligible to go ahead with your applications for that certain specialty. At the same time, it also means that most probably you'll be a registrar working in that specialty at the time of the application. Satisfactory, you can still go for the appointment, yet it will affect your ranking later on. All right, so most probably you won't have the best of ranking, but you still have the chance to. Not appointable. 0 commitment means even if your scoring was like you scored 42 in your application, you are not appointable for that certain specialty that you have applied for. And this actually does happen a lot. So people who have perfect application scores, but it's quite general and it's not, you won't still get the chance to apply for that application, unfortunately. You will find this commonly in patients in specialties like gastroenterology, cardiology, and renal, because those specialties are very specific. So either you have commitment to it or you don't. Other specialties like acute medicine, because all of us have worked in general medicine at a point, you might have a better chance to show commitment to it. Okay, continue with the commitment. There are 20 marks available from the combined scores of the 2 assessors. So it will make 20 marks out of the total 70 marks of your applications. That means 29% of the marks available at the short listing stage for the specialities that used it. Okay, What does that mean? If you go back to, did we show that? We didn't show it yet. Okay, we'll go back and I will explain this point. Okay. Postgraduate. With Marwa have already mentioned this part. I'll just mention it in a little bit more details, which is basically if you have a PhD or an MD, like our colleagues who have completed the MD in Sudan, they're lucky, they can have 4 marks here. Or obviously if you have a PhD in your specialty. Master degrees will give you 3 marks. If you have any other postgraduate diploma or postgraduate certificate, but it has to be minimally 1 month, between 1 and 10 months, then you can score 1 degree or 1 point. In this part of the application or the self-assessment, you cannot Hello everyone, I'm terribly sorry. Do you mind if you keep your microphone silent, please? Adila Ahmed. Thank you so much. Sorry for that. Okay, so for MRCP certificate will not be considered as a postgraduate certificate. And unfortunately, teaching postgraduate certificates will also not be considered as a postgraduate certificate. If you have whatever degree in teaching, it will only be accounted in the degree in teaching. It will not be accounted. Even if you have a master in teaching, you cannot put it here at the, or you cannot provide it here at the postgraduate certificates. Additional achievements, those are the achievements you were rewarded in the medical school. So if you were like, if you have a higher achievements awarded for primary medical qualification, you were graduated with distinction or honors or so, that it's not awarded to the top except for the top 18, means whether you are the first or the second in your class, basically. And then you will be awarded 3 degrees or 3 points, awarded international or national prizes related to medicine. Whatever prizes you got in medicine, whether internationally or nationally, then you will have 2 points, 1 or more prizes. In obviously your medical school or medical college, then you will have one degree. You have to, the unfortunate thing about it is that it has to be clear in the certificate you have that it's not awarded to more than the top 20, which most of us, when we have prizes, is not really mentioned, but it's really required in this self-assessment, additional achievements. MRCP, you've asked about this point earlier, Marwa, whether it will be counted or not. It does actually. So it used to be counted up until 2019, and it used to completing the 3 parts of the MRCP used to count for 12 points actually, and it came down now to 8 points. And then from 2019 until 2022 was not it was not part of the self-assessment, because obviously the PACES exam itself was delayed or like even withheld for a long time. So if you have the full MRCP, you will have 8 points, and if you passed part 2, you'll have 6 points, and so as you can see here in the scoring system. Okay. Now the thing is that if you don't have the full MRCP by the time of the application, you can still have you can still apply and you can still have points. Yet you will not be allowed to join the certain specialty unless you complete the PACES. So because basically if you're applying now, you will join the specialty by August. But if you fail to pass your PACES exam by August, then you will not be allowed to join the specialty. Presentations, as you can see here. Now the difference is that there was a little bit of differences between this year and the year before in the scoring system of the oral presentations, because as you can see, it used to be 8 marks and so on. Now it's different, but my colleagues have already been through that, so I won't go through it. But you will notice that the oral presentation would give you more marks than the poster. Okay. And publications. Now, the highest, if you're publishing in PubMed, obviously it gives you higher marks. If you're publishing more than 1 presentations in PubMed, it gives you higher marks. Yet the highest mark would be for researches and not only papers. Okay, and this is to continue the publications. I'll go quickly through this. So this year they've added in the press as well, which was not there before, I believe. So meaning if you do have an interview, for example, in a certain channel, even if it was a local channel, our colleagues from Sudan, some of them do have interviews or like do have, was there at the media at some point, especially TV channels or so, please include the link to this interview and this will be counted. So this year they are counting the press as well, not only the PubMeds and the journals. The teaching. So the teaching is the only thing that is subdivided into 2. There is teaching and there is or like a certificate in teaching or like a degree in teaching, let's say. Okay. So as you can see here is as my colleague have said earlier, the highest marks will be for someone who is organizing teaching, like is doing the journal club. He's in charge of coordinating the journal club, but it should not only be coordination. Make sure if you are entitled of it or like in charge of organizing a journal club, when you claim for a certificate, ask them specifically to mention that you are organizing it, but you're also presenting regularly in it. Because if you're not presenting in it, then this is a leadership rather than teaching only. But if you're organizing and presenting, this will count for the full mark. Okay. Training and teaching, master degrees will give you the highest mark, obviously. And then if you have a PG certificate or diploma, will give you 2, which is again less than last year, but anyway. And you have training and teaching methods, you will have 1 point. That means teach the teachers is 1 point only. Whether it was 3 days or 1 day, it doesn't matter, it's 1 point. Last year it was different. The 1 day was 1 point and the 2 days were 2 points, but this year, whatever the course is, it's 1 point only. Okay. The QIPs, now the differences between this year, I believe, and the last year is that they're clearly asking you, in order to give you the highest mark, you should be having a leadership in this QIP, and it should be all aspects of 2 cycles. And it means that most probably you should be the presenter, you should be the main presenter or founder or like of this QIP, because they want you to have the leadership of that. All aspects of 2 cycles of QIP, but you don't have that leadership capacity and you're not supervising the others, will give you 4. Okay, so if you're not the main person who's doing the QIP, but you're still involved in 2 cycles, you'll be 4. Okay, a single one will be 1 only, a single cycle. By the way, I just want to add, QIP, whatever topic you choose, as long as it's 2 cycles, it is QIP. It doesn't really matter whether this topic is something important, not important, is a very, because we were asked this question before, whether this is a very minor subject, like, for example, like checking the TEP forms, whether it's done or not done. It is a QIP. It might seem simple, but it's still considered QIP if it was 2 cycles. Okay. QIP evidence. Now, either you have the QIP form, which is a certificate that is given to you from the postgraduate center, and it clearly mentions that you are the you've done the 2 cycles, and this was your role, and it was done this year, and so that is a certificate. Okay. Or if you don't have that certificate, then you have to have a headed document. from the supervisor or the organizer that mentions all of this information in it. So either you have a form signed from the postgraduate center, or you have a certificate headed from the supervisor that mentions all of this things. Okay. And the leadership, national or regional leadership was support. Hi everyone. So sorry, if you can kindly just keep your microphone silent. I'd be grateful. iPhone 6s Plus, please. All right, so leadership, as you can see, if you're national or regional, it's really difficult to get that. But if you are very lucky to have it, has to be 6 or more months, and you will have you will score 4 for this. I'm sorry, just give me a second. Hi, so sorry for this. Okay, so if you are having the local leadership, then you will score for 2. Okay, so if you are, I'll give you examples for this because many people are asking why. Organize the M&M meetings, the mortality and morbidity meeting, for example, this will give you 2 points. If you are organizing a journal club, it will also give you 2 points. Any sort of teaching that you're organizing regularly, it has to be regularly, over 6 months or so, this will give you 2 points, okay? Evidences, all evidences need to be uploaded. For this cycle, it will be from the 4th of the 1st of January until the 12th of January, okay? So it will close after the 12th of January. Please do not include any achievements unless you have an evidence of it, okay? Anything that you don't have an evidence for, it will not be considered. Publication evidences can be either a certificate or a letter confirming the invitation and or the delivery of the presentation or the poster, an abstract submitted to the organizer, inclusion of the abstract book for the meeting, a copy from the presentation slides or posters and so on. So it doesn't really have to be like, if you have an evidence that you will present in a certain conference, but this conference is going to be in March, for example, but you have an email that says, or a certificate from the organizers that you will be presenting with your name on it and the name of the subject you're presenting, or sorry, the article you're presenting, then this should be counted, okay? Unfinished diplomas, courses will not be considered. Yet you can still include them, but not in, try to include it in the commitment rather than in the postgrads or in any other self-assessment. It will be considered as a commitment to that specialty, but it will not be considered as a certificate, okay? Before the interview, make sure of the following. I know my colleagues have mentioned that already, but it's really, really important. That's why I'm mentioning it again, okay? Make sure you have an appropriate internet source. Check your device suitability. Make sure it's a hand-free device. Please try not to hold your device on your hand. Many issues happen where my colleagues have unfortunately dropped their iPad or dropped their mobile phone, and it was really inappropriate during the interview. Please avoid using your mobile phones if possible to avoid having calls or messages that would disturb you during the interview. Ask for an off day or half off day in the interview day. For our colleagues who are working in the NHS, usually the NHS policy would support this. So if you ask before a decent time, they should provide you with at least a half day for your interview. Okay, check the place where you're having your interview. Please make sure, don't leave it till the last minute. Okay, interview link, check it please beforehand. It happened to me before that my interview didn't, my link didn't work. And I had a major issue where my NHS email was blocked for a reason. And usually Yeah, try to check it before time. Okay. Know whom to contact in case any issues like this happens. So they would send you an email whenever you book an interview. They will send you an email. It says in it at the bottom of the email whom to contact if you have any issues. Okay, so try to make this in reach on the day of the interview. Okay, don't panic. Troubles can happen. Usually they're very understanding. So just try to contact them. Obviously, if it's not something from you, like you're having to delay for any social reason or whatever, but if it is something that you don't have hand in, like for example, my email that was blocked and the link didn't work, they're very understanding. They will try to help you as much as possible, and they won't just cancel your interview for this kind of reasons. Okay. Most important thing, be on time. It's a very bad impression for them not to be on time. The interview, as my colleague have mentioned, I won't really go a lot through it because they've mentioned it already. We will go to the questions and scoring. The first line here, this, if you remember, we spoke earlier that the interview is 20, it counts for, you have 20 marks for it. And the 20 marks comes from here, because those are 5 questions. Now I'm talking about cardiology specifically, okay? You have 5 questions, and this is interviewer number 1 and interviewer number 2, okay? And this is called the weighing. I don't really understand it very well, but I know that whatever the mark they give you, they will multiply it by a certain number, but I don't really understand I don't have a very good understanding of the weighing. What does it mean? And this is the maximum score that can be given to anyone on that certain question. In cardiology, we have 5 questions. Suitability and commitment is number 1. Number 2, medical registrar suitability. And this is non-cardiac, this is acute medical, because obviously all specialties are dual specialty, aren't they? And then professionalism and governance. 2 clinical scenarios. Okay. And this is the scoring. Poor, 1 point. There's no 0 point in it. Okay. The 1 poor is the least one, and I haven't heard about someone who scored poor so far. I might not have the best experience, obviously. I don't have a lot of experience in it, but as much as I had, I've never heard of someone had a poor one until now. 2, it happens. And this means that area of concerns, it means that you were not really great in your answers, maybe not organized. They will always give you the feedback. You try to look for the feedback, try to see what have you done wrong in order to improve it the next time. But hopefully, inshallah, all of us will do good. Okay, 3 is satisfactory, 4 is good, and 5 is excellent. Okay, appointability requirements. My colleague have already been through it. Most important thing you need to know is that if you ever scored at any of your stations 1/5, you won't be appointable. You should not have more than 2 in your 10 interview scores that is 2/5. And that obviously the RIS, which is the row interview score, should be 30 or more. Okay. If you have all 3, then you're appointable. If any of the all 3, which is from 2 until 3, here's like 1/5, 2/5s, and the total score of 30. If you don't have any of them, then you're not appointable. Okay, moving to the cardiology. Why cardiology? Cardiology is the specialty that combines, or it is a specialty that combines clinical, radiological, surgical skills all in one specialty. It is a specialty which makes a lot of difference in both quality of life and life expectancy. And that's why it's extremely rewarding. What people think about the UK cardiology training pathway, the most positively rated aspect of the UK cardiology training pathway were opportunities for research, followed by fulfillment, earning potentials. Obviously, it is one of the specialties where you can do a lot of private work because obviously it's a skillful and there is a lot of procedures that can be done in cardiology, and many of the people would prefer not to wait to be scheduled under NHS, which can take months, and then they would go for the private route, and that's why it has a very good earning potential, impressiveness to others as well, which I don't know. Some people have, some people don't. The most negative rated aspects were competitiveness and inflexible hours. Obviously, it's very competitive. One of the reasons why is because you can only apply once a year, so you have to wait for a whole year in order to apply again for cardiology if you did not secure a number. The other thing is the inflexible hours. I'm sure if anyone listening to us and you're working even as a trust grade registrar like myself, you will find that in cardiology you will have sometimes, unfortunately, to stay a lot after hours. It's not very flexible. Lots of on calls, night shifts, very stressful, but again very rewarding. And if you like to keep your hands busy, it is one of the specialities that you'll always be busy in, and you are using a lot your surgical skills in it. How to show commitment to cardiology? As my colleague has said, commitment to any specialty is almost the same, isn't it? So the first thing, if you're an IMT doctor, make sure that IMT 3 is in cardiology if you are interested in cardiology. If you don't have this opportunity, try to have at least as much shifts in cardiology as you can, okay? Sometimes, like Buckinghamshire, we have two different, we have a hospital which is for cardiology and stroke only, and the A&E of that hospital is pure cardiology and stroke only, called the CSRU, Cardiology and Stroke Receiving Unit. And in the worst case scenario, try to get shifts in the cardiology and stroke receiving units if you can, and try to get a certificate that you have been working in the cardiac A&E. Okay, if you cannot secure any job in cardiology. Non-training posts, as I said, in a chosen specialty, clinical fellows. There are loads. You will notice that in the UK there are loads of names for a registrar post. There's SPR, SAS, LAS, locum, clinical fellow, whether junior, senior, different names for a simple term, which is non-training post. Okay. Now the taster week, as my colleague have mentioned, either you organize a taster week, which does not sound very easy, I know. If you can't, try to join taster weeks. There is always taster weeks in all specialties, and there is one in cardiology as well that you can find in the DSG. Join researches in cardiology. Always check with your educational supervisors. If you go to the cardiology units, they always have a research office, and then you can go there and ask if you have any research going around. They would always have some. Try to join it, okay? Have a postgraduate studies in cardiology, which is costly, but if you can, it will be very helpful. QIP in cardiology is really easy. You can choose a very simple topic and go for a QIP, 2 rounds. That's the most important thing, and this will show you commitment. Now, there is one important point. I know that Marwa mentioned earlier, which is known for everyone, that you don't really have to have the QIP in the same specialty that you're applying for. Yet, I had some of my colleagues, they were specifically asked during the interview whether you do have a QIP in cardiology or not. So if you would like to apply for cardiology, it would be very helpful to have a QIP in cardiology, okay? It's never too late. We still have a few weeks left. You can try to do at least one cycle in it, okay? Presentation, case report, and publication in cardiology, if you can. Become a member of a cardiology organization or body, example, ESC, any other organizations of or bodies. There is the Cardiology Junior Association.
If you could,
sure. I think probably this this will be this or the next one will be my last one. Join cardiology clinics, cover cardiology clinics, and mention them, please, when they ask you for this question. Have the Part 1 echo exam. I did not specify. You can have the European one, you can have the British one. At least have one. If you, now this is new for this year, if you're signed off from any competency, please include this certificates of competencies, for example, pacing, echo, PCI, anything that you're signed off, because obviously you're asked for a certain number. If you're signed off, please put this certificate in your presentation or in your application. Okay. And best of luck for everyone, inshallah. وبالتوفيق لنا جميعا. Okay, thank you so much for this opportunity. All right, moving to the next presenter.
Thank you so much, Rihan. It will be me. Just a second, I will be sharing my slides. Could you stop sharing? You have already. Right. Good evening, everybody. I would like to take the chance to thank SECT for organizing this opportunity for us to present about our medical specialties. I will be presenting about renal specialty commitment and scoring, and a bit of talk about renal transplantation and donation. I'll reintroduce myself again. My name is Marwa Ahmed. I'm one of the specialty doctor in renal medicine. I'm working at St. James's Hospital, one of the bigger kidney centers in UK, and it is one of the main hospital of lead teaching hospitals. Right. So it's been mentioned about the training application already, just consolidated what has been mentioned. In regard to renal medicine, it is group 1 specialty. By finishing the training, you will be accredited dual accreditation in general medicine and renal medicine. And if you would love to, there is a possibility you can gain triple accreditation. Addition to these two is the intensive care medicine. Renal medicine suits people that who like to deal with wide variety of patients, because the specialty offer opportunity to deal with very unwell patient to very stable patient on dialysis unit or in clinics. It's ups and down, adrenaline charge, and quite challenging, and it's need someone that able to work with some independence, because quick responses are required, and able to provide help and guidance for people remotely, calling from district hospital, dealing with renal patient at their sites. And the field is providing wide range of opportunities for researches, monoclonal treatment, immunosuppression treatment. A lot of research is going on at the moment for treating glomerular disease and transplant, and more invention in this particular field. And also it's a procedural field. People like intervention, it's specialty of choice. Just to consolidate the renal application, it's all like the other medical specialty application. The commitment for renal could be shown as working in a renal medicine department, preferably as a specialty grade, able to conduct variable procedure in renal, temporary or permanent catheter insertion, have a knowledge about kidney biopsy, and if you have done one, that would be great. Able to manage all kinds of renal diseases that you could come across in ward, clinic, or as an outpatient. Have a knowledge about the transplant projects that's running, studies that are running at the moment. You could also show commitment by attending educational events, conferences, courses by UCL or UK Kidney, and degrees on renal specialty, and audit project, presentation, and publication related to this specialty. This has been mentioned before. The commitment is very varied from 10 to and 0. There is nothing in between. Either you committed or you marginally committed, or you has no any commitment, and that make you unappointable. Right, so this is the shortlisting score for the year 2020 round 1, and the applicant at that point were 174, and the average of the interview score was 39. It's quite competitive, actually, competitive specialty, especially to show commitment for the renal medicine. And this is the form for round 2. And again, the applicant were 73, and the average of the interview score was 36. So dates related to the renal specialty, the application date as all the specialty is from 17th of November to 8th of December. Submission of evidence will start from 11th of January, and it will end on the 18th of January 2023. The interview dates are from 21st to 24th, so 21st, 22, 2nd, 23, and 24th. March 23. The interview C will consist of 5 stations. The first station will be clinical scenario. Basically, they will give you a clinical scenario, and they'll give you like 2-3 minutes to think about it. You're allowed to write notes about that scenario just to help you run the interview. Obviously, it will be a renal case to manage. They're going to assess your clinical judgment and your way of escalation and your safety as a renal doctor. And when you escalate your senior, and when to involve your senior, and how you communicate your plan of management with your health professional, or the patient themselves or their relative, and when to decide to not to treat, and how to de-escalate and decide taking the non-interventional course, and your safety, when to transfer a patient from, for example, a district site or district hospital to a tertiary center for kidney support, for example. They will test that you are able to judge the safety of transfer, like making a decision transferring a patient with a potassium of 6.9 for dialysis at a dialysis center. That shouldn't be right. So this kind of decisions need to be thought carefully. The second station will be an ethical scenario. Again, the medical dilemma of, for example, patient lacking capacity, or conflict of interest of patient and their relative, or the power of attorney and the medical best interest, this kind of scenario. In renal in particular, they can ask you about, is dialysis is appropriate decision to be taken for this patient, or we need to think of withdrawing treatment, and how to approach this decision, and whom need to discuss this decision and with whom. The third station it's not an actual station. It's your communication through the interview with the rest of the station, how you communicate with the interviewers, the way of your communication when the scenario states that you need to speak to a patient, to speak to a relative or one of your colleagues. So your communication way will be tested this way. It's not an actual question on your communication that you need to answer. Medical registrar suitability, this has been introduced, I think, in recent years. So basically, it's not a medical question, it's how you deal as a medical registrar on duty, managing the hospital issue, like discharge planning, bed crisis, escalation to ITU level 2, or moving patient out of this area, and whom to be suitable to swap patient. For example, if you have unwell patient in the ward and you need to find a bed in this level 2 or level 3 area, and bad handover, inappropriate colleague or junior, senior, this kind of situation. The and discharge planning as well, MDTs. So it's basically tells that you are able and competent in working as a medical registrar at the NHS. The commitment to the specialty is just taking you on the stuff that you have mentioned in your application. And if you have done anything after you have submitted your application, you can mention just to strengthen your commitment to the specialty. They will go through the things that has been mentioned in more clarification and checking what you have written is right and correct. This time, the renal specialty has advertised for it. This number might change a little bit up or low, depend on the numbers of trainee at the time of the offer date. It might change by movement of trainees. Some people could leave the training, or some could stay longer by extending their training for any kind of reason. That was it about the application to renal medicine specialty. I'm going to speak about renal transplant for people who are not used to, or they don't deal with renal transplant. As you can see, we have our little vein situated above the right iliac veins and arteries and connected to them. And its ureter connected to the bladder with the presence of the native ureter, both sides. So I'll take you through a little bit about the transplant history, especially kidney transplant history. The first transplant happened in 1902, and that wasn't successful. They kept doing so. Each success is a result of multiple attempt or failed attempt. The first successful transplantation was in 1953, but that was temporarily successful, and it was from a mother to her 16-year-old boy. On 1954, a milestone was made, and they successfully managed to transplant from monozygotic twin, and that graft has survived for 8 years. And that has been done by Joseph Murray, who honored a Nobel Prize for that achievement in 1990. 1962 was the first kidney transplantation between genetically non-related patient, and at that time they used the immunosuppressive medication to save the graft surviving. So transplant is not most of the people are not familiar with, so I'm going to mention a bit of the terminology that the transplant team use, or people deal with transplant use. We have for the kidney, we have a term called preemptive transplant, and that entails that when patients reach their stage 5 kidney disease, but they haven't started dialysis and they got lucky and got a kidney, we call that preemptive transplantation. And then we have a kidney transplantation and simultaneous pancreatic and kidney transplant, and simultaneous liver and kidney transplant, and in-block transplant. For in-block, if you can see the picture in the right-hand side, the first picture that I showed you about the transplant was a single kidney overlying the iliac vessels. But here we have two small kidney, smaller in size, and they came with their native, their own renal vein and the inferior vena cava and their renal artery and the aorta, and these anastomose with the iliac vessels and the two ureter inserted in the bladder. So that's the in-block. It's usually a pediatric disease donor. Because they are relatively small, they use the two kidney to provide a transplant for an adult, and it can be donated to pediatric as well. And we have the two types of donor, live and deceased. Live donor can be related, blood related, or non-related, like spoke. And altruistic is someone who's just donating a kidney to someone that they don't know, but they are quite enthusiastic helping kidney patient by donating their kidneys, one kidney actually. And it could be part of an exchange scheme. In this scheme, one of the kidney recipient, the CKD patient, have a life-related donor or unrelated donor, but for some reason they are not matched to get their kidney. So they go in pairs and try to find a match with another pair who they are in the same situation. That we call it kidney exchange scheme. And then the disease, we have a disease after cardiac death or disease after brain death, DCD and DBD. And then we have the concept of mass mismatch, which shows the whole dilemma about the transplant and the challenges that we face with transplant is the mismatch. It's basically about the HALA mismatch, mainly HALA A, B, and DR, and additionally CW and DQ, and ABO system, the blood group, and clinical characteristic of the donor and patient. And then we have rejection. When we say rejection, the transplanted kidney is being attacked by the recipient own immune system. We have two types of rejection, humoral or antibody-mediated rejection and cellular rejection. From the name, it's cells, the immune cells attacking the transplanted kidney. And the rejection can be hyperacute from the moment of the transplant, acute in the first weeks, and chronic months to years after. How the transplant process happen for the kidney from deceased donor specifically, because for life-related, either they get matched and they donate to their loved one or go through this exchange scheme. Deceased donor, because it is something national and needs arrangement, so that make a little bit of fairness on providing this transplanted kidney. So once patient is at the end-stage renal disease, they got assessed for their suitability for as a recipient for a kidney. Obviously, it's a major surgery, so the general of major surgery suitability, and specific for kidney transplant that they have a site that we can fit the kidney on and a good vessels that we can connect the kidney vessels to. And then once they have met this criteria, they're going to be listed for the transplant and stay active on this list. And then they will consent them in clinic, despite we don't have a date for the transplantation time, but we consent them in advance, because when we get an offer, that can happen in the midnight, in the weekend, and that has to be very quick. So they assess the patient and they consent them through all the process, the surgery, the immunosuppression, the rejection risks, complications that could happen because of the presence of the kidneys, and complication could happen because the quality of the kidney. And sometimes recently they started transplanting kidney from hepatitis C patient. They need to consent them for that because it is treatable. So the quality between the equation between getting a transplant and getting a treatable virus, it's better to get that. So they need to discuss that risk, and also to consent them for any ongoing research on that center that are located on. And this consent process revised annually, just to check with the patient. They are happy they haven't changed their mind. And next step, regular monitoring for the patient, because as we said, kidney disease is a major risk for a lot of complication, specifically cardiovascular complication. And at some point they might be unsuitable for transplant for whatever reason. And also we monitor their sensitization, because at some point they might develop antibodies at some point, because this monitoring involves testing patient for sensitivity for available donors and the donor list or the donor pool. So we know if these patients are suitable to get X or Y kidney or not. And during this assessment period, people can get suspended from the list. That means they are not active. Even if matched kidney found, they will not be able to have it because for some reason they are not suitable at this particular point, and they have an ongoing medical issue that could be solved. And once it is solved, they will become active again. Other thing that they can be removed completely, they will not be able to go back to the list of the transplant, of waiting for the transplant. And then the next step is finding a suitable match donor. As we said, we check their sensitization, the presence of antibody to the donor pool, and once there's time, they'll get that kidney if it is available. And then we have the priority, who's come first on the list. We have to group TIRA A and TIRA B. Group A are people who are waiting for longer time. The cutoff is 7 years, and people who are sensitized against most of the donors in the donor pool. And these people have priority, so they will be on the top of the waiting list. I will use this chance to speak about the transplantation and organ donation issue. الله تعالى ومن أحياها فكأنما أحيا الناس جميعا. I would like to thank all donors who have participated on making one patient, and not only the patient, but their whole family, friends, and everyone knows them, having the chance to survive because of their donation. Their contribution is priceless. Kidney donation is challenging, and the challenge that face kidney donation is the increasing number of patients that needing renal replacement therapy, and the sensitization issue that could happen through pregnancy, blood transfusion, and sometimes no reason for sensitization, just people found to have antibodies to almost everybody on the in the donor pool. And the long waiting time and the suspension or removal from the waiting list also another challenge. So how to overcome these challenges? If you could able to prevent the CKD or slowing the progression of CKD to reach the end of the stage of needing renal replacement therapy. And one thing that we can do is optimizing the anemia management to just try avoid blood transfusion. Blood transfusion is full of risk. Please be mindful and take a minute and think about, is it right to transfuse this patient or not? Is the patient is candidate for transplant or not? Just have a thought. Another thing about your decision about blood transfusion, if there is any way to avoid it or not, but sometimes we run out of option and we need to transfuse because it's a matter of life-threatening situation. And the other thing is increasing donor pool. So the authorizing body regarding organ donation is the NHS blood and transplantation. Their websites give a lot of information about the organ donation and how they organize these things. So why to donate? For the reasons that I have mentioned before. What I can donate as a living, you can donate 1 kidney or part of your liver, part of your liver. As a disease, you can donate heart, lungs, liver, kidney, pancreas, small bowel, tissues, cornea, and bone. And how to donate is basically get in touch with the NHSPT. Whatever you decide, please talk to your loved ones, because it's basically, if it is disease donation, the body belongs to the family. So ideally, they should be involved in this decision. And to donate only some organs you can choose, donate liver, not kidneys, or whatever the choice the donor decide is their right. And then at any point, if the donor change their mind, they can opt out of this donation scheme. Right. We got our patient transplanted, how we can manage them, what could happen, and how we can manage subsequence of the transplantation. So acutely post-op, this is usually done by renal team. I don't think non-renal team will be dealing with this. It's post-major surgery management, pain management, and oxygen, thromboprophylaxis, and prevention of atelectasis, getting them on a spirometer regularly, and fluid management specifically for the transplant patient. We need them euvolemic to overvolemic site, maintaining the good blood pressure to perfuse this new kidney. And the new kidney is normal kidney, and once it's in the body of the CKD patient, it will try its best to clear this toxin. So we'll expect a huge amount of urine and electrolyte disturbance because of the urine output is high, and we expect the blood pressure is low. So we ensure that we are giving them adequate amount of urine, either IV or orally, and we checking and correcting the electrolyte promptly. And additionally, to keep the graft surviving, it has they have to receive immunosuppression preoperatively. Most of the centers do induction with the high dose treatment of steroid and another treatment for T cells. It's the strategy differ from center to center. I'm not going to dive into that. In the longer term, other non-renal doctor can face and dealing with the patient. Basically, it's maintenance of their immunosuppression treatment, low dose, and CKD managed. They are no longer will be a normal kidney. They are CKD regardless of their creatinine clearance. And one thing we need to be thoughtful about is their creatinine clearance will improve with the transplantation, and most of the medications that the patient they are receiving might need adjustment based on the creatinine clearance. For example, epileptic patient, they need adjustment for their anti-epileptic, otherwise they're gonna end up with uncontrolled seizure. And screening for complications, they are immunosuppressed, so they usually screening for immunosuppressed patient. That everyone can do. Right, what complication could happen and what are the possible causes for it? Hypertension post-transplant, either because of fluid management, we couldn't manage the fluid appropriately or replace their fluid needs appropriately. And the other thing is these people had a major surgery and a lot of anastomosis between vessels, renal artery, renal vein, iliac artery, iliac vein. They could be bleeding from that, so check they are not bleeding. Reduced urine output could be as a result for the above one, or as a result of complication of surgery or complication of non-functioning graft. Anuria, usually it's for the result of the hypertension, but we need to think and bear in mind that maybe due to arterial, the kidney is not getting blood to filter urine, and hematuria probably due to renal vein thrombosis. So these things need to be aware of when you face this presentation. Hyperkalemia, again, as a result of any of these or graft dysfunction. And sepsis, this patient has a surgery, they are already immunosuppressed because of the CKD, and again, we suppress their immunity by giving them a potent immunosuppression. So pneumonia, surgical site infection, and urinary tract infection. And one thing to mention, these people, when they get transplanted, the anastomosis ureter of the transplanted kidney, it will be stent for a few weeks. So they have a foreign body in their ureter that also can increase the risk of urinary tract infection. Late post-transplant presentation and reduced urine output. Again, just apply the usual cause of reduced urine output or usual cause of AKI. Is it something pre-renal, renal, or post-renal? Is it hypovolemia? Is it kidney impairment due to rejection, infection, any kind of thing, or obstruction after the bulbocollateral system? Worsening graft function, again, is it something related to pre-renal, renal, or renal, specifically with transplant, the graft rejection, or recurrence of the previous kidney disease, like glomerulonephritis as a cause of their initial end-stage renal disease. Hyperglycemia, probably from their immunosuppressive medication, they do increase the blood glucose, like steroid and tacrolimus and cyclosporine. Liver impairment, that could be a result of their immunosuppressive status that make them prone to viral infection like CMV infection or medication side effect. Constitutional symptoms is they are transplanted and they are immunosuppression, so they are at risk of post-transplant lymphoproliferative disorder. That a thing that we need to bear in mind. So you can face this presentation at your non-renal placement. Just please and always seek renal team input for a transplant patient, whatever was the presentation. Whatever you do to the renal transplant patient might affect their kidney. So ideally, you need to get help from expert. If you started a treatment that could affect their kidney, could affect their immunosuppressive level by cytochrome B45-0 inhibition or induction, you can use any nephrotoxic medication. You can alter their fluid status. So anything that can affect the kidney. And we got mocked a lot about our tiny beans. Yes, it is tiny bean, but it is priceless for us. So please get in touch with us if you are doing anything for any one of the kidney transplant patient. Any question? Right, I will take that and I don't know. This are my references for this presentation. If you come up with any question, just pop it to the chat. I will answer it later. We'll move to our next speaker, Wala Merghani. Wala, are you ready?
Yes. Assalamu alaikum.
Alaikum assalam. Go on.
Assalamu alaikum. My name is Wala Merghani. Currently work in general medicine in Gloucestershire Royal Hospital. Today, I would like to speak about the drug-drug interactions in the renal transplant recipients. Slide. Yeah, the immunosuppressive agents are crucial for successful kidney transplantation. They are used as induction, maintenance therapy, and treatment for graft rejection. The drug-drug interactions considered as a common complication in the post-operative care among the renal transplant recipients due to the polypharmacy or co-administration for other medication of other comorbidities like hypertension, lipidemia, or psychiatric disease, which attributed to life-threatening conditions if not treated successfully. Therefore, the close monitoring and evaluation for the drugs remain the critical key to prevent the potential adverse effects on patient care. So the cyclosporine, tacrolimus, mycophenolate, sirolimus are all metabolized by cytochrome P450 enzyme system. These drug interactions could increase their level in bloods, resulted in nephrotoxicity, or decrease their level in bloods, lead to inadequate immune suppression and cause transplant rejection. So I would like to present one case that has been reported during the pandemic COVID-19. In the next slide. Sorry. Can move to the next slide, please. This case has been reported in some problems. Hello? Okay. Hello? Are you hearing me well? Hello?
Guys, so sorry about that. I don't know what happened. Can you hear me?
Yes, I'm hearing you.
Okay, sorry for that. Just my computer playing funny with me. I will share in a second. Actually, this is not yours. Can you see now?
No, not yet.
That's not yours again. What's happening?
Let me try from my side.
If you could do so, yeah.
Just a moment. Oh, yeah. Okay.
Can you?
Yeah, okay. Everyone can see that?
Yeah, we can.
Okay. Okay, I would like to present this case who has been reported during the pandemic COVID-19 in Italy on March 2020. This young lady, known case of senior Loken syndrome, which is very rare genetic disorder manifested by retinal atrophy causing blindness and nephrolithiasis lead to end-stage kidney disease. However, this lady had underwent to two surgery for kidney transplantation, one for living donor kidney from her mother, which is failed in 1995, then went to the deceased or cadaveric kidney transplantation at the same year, which successfully treated. Then at that time, she was on cyclosporine, basiliximab, mycophenolate, mofetil, and corticosteroid as induction therapy. Then as a protocol of the management, she changed to the tacrolimus and corticosteroid. Her average, the average of her serum creatinine was between 1.5 to 1.8, and the tacrolimus trough level between 5 to 7 nanogram per ml. During pandemic, she had swapped for COVID, as she contracted the infection from her mother who admitted in hospital due to COVID pneumonia. At that time, she had a mild complaint of cold, cough, and fatigue, no fever. Vital signs were stable. Her investigation were unremarkable, apart than neutrophil 17.2, increase in creatinine to 2.29, T-reactive 67, and a slight high in the interleukin 8. Her chest X-ray confirmed reticulonodular opacity in the left lung, which then been diagnosed as COVID pneumonia and admitted to hospital, for which she was given combination of lopinavir and ritonavir, along with hydroxychloroquine and ceftriaxone. In subsequent, on day 2, she developed nausea and diarrhea. So the antiviral medication replaced by other combination of Danuvir and Covigstat, but her condition had worsened over the next 2 days. Tacrolimus trough level reached 90 nanogram and creatinine 2.19, C-reactive protein to reach 131. So the management plan to immediately they stopped the tacrolimus and antiviral medication immediately, and to continue on corticosteroid therapy only, and to keep eye on tacrolimus level. In subsequent days, GI symptoms and respiratory symptoms improved, along with significant dropping of tacrolimus level to 18.8 on day 9 to reach 15 after 2 weeks. And the creatinine came down to 1.7 in the baseline. In the discussion about this patient, she has manifested atypical sign of tacrolimus toxicity due to administration of viral medication with tacrolimus, which which in cytochrome P450 or 384, leading to increase in her increase in the tacrolimus level in her blood, causing toxicity and affect her renal function consequently. Once the tacrolimus had stopped and corticosteroid increased and replaced, the tacrolimus trough level and creatinine improved, in addition to decline in the inflammatory markers and interleukin 6, which has recognized as a sign of progression of COVID pneumonia. The transplanted kidney at risk of drug interactions. When these drugs are, when used medication that metabolized by cytochrome P450, either to increase or decrease the effect, to increase or decrease their effects in blood. I would like also to talk later on about the life attenuated vaccine, which harm the kidney, the transplanted kidney. I will give some examples of the medications that we call cytochrome P450 inhibitors, which increase the level of tacrolimus in the blood, leading to toxicity. These are antifungal, antiviral, antibiotic, some medications, HIV medications, calcium channel blocker, cholesterol lowering drugs, famotidine, methylprednisolone, metoclopramide, fluvoxamine, and herbs and juices like grapefruit, which is the famous one. The other medication is the inducer. These examples of these medication which induce the cytochrome P450, but decrease the level of tacrolimus in the blood level, causing graft rejection. Regarding the life attenuated vaccine, I would like to highlight regarding the life attenuated vaccine in the transplanted kidney, which is contraindicated for any immunosuppressive patients or transplanted kidney to be offered any life attenuated vaccine, like mumps, measles, rubella, varicella zoster, yellow fever, intranasal influenza, or oral typhoid. Regarding the immunization, it's the transplant recipient at high risk of infection due to immunosuppressive illness and drugs. Thus, post-transplant vaccine are highly recommended for those who deliver no vaccine before undergoing renal transplantation. It's advisable to give the vaccine post-transplantation rather than prior to transplantation. And the protocol for the immunization, it's can be varied over the hospitals, but most of the hospital give the pneumococcal vaccine, influenza, diphtheria, hepatitis A and B, and tetanus after 3 to 6 months post transplantation, and when the immune response detected low. Pneumococcal vaccine is given every 2 to 5 years. Influenza vaccine given annually, and the second dose after 5 weeks of the first dose. And the live attenuated vaccine are contraindicated among these patients. Again, also I want to talk about the COVID vaccine. The COVID vaccine are strongly required to avoid the risk of COVID infection despite the undetermined immunity and effectiveness of the vaccine in such patients. There is no sufficient studies to determine the benefit or the non-benefit of vaccine among these patients. So it came to the end. The drug interactions are frequently common among the transplanted recipients due to the narrow therapeutic range of immunosuppressive drugs that are used with multiple medications related to other illnesses. The clinician should take into account the patient's drug list and careful monitoring of drug interactions to provide optimal care for such patients. Additionally, vaccination is pivotal to avoid preventable infectious disease in patients with a low seroconversion rate. However, further researches are required to explore the immunological response after vaccine and to conclude the requirement of an additional booster and approval of live vaccine among those people. And thank you. If you have any questions.
There is one question, but we'll keep it for the last. We're gonna go for Riham presenting about escalation plan. Riham, are you ready? Well, you can end your.
Assalamualaikum.
Alaikum assalam wa rahmatullah.
Hi, hello everyone. My name is Riham Mahdi. I'm presenting again because we couldn't record my first presentation, so I'm going to present again. Thank you for waiting. If you can kindly, Marwa, share the presentation, please. Thank you very much, Marwa. Bismillahirrahmanirrahim. Salam for everyone one more time. So I'm going to present the treatment escalation plan one more time, which is known in whoever working in the NHS as the TEP form. So if we move to the next slide, please. So the most important thing about it is that the decision do not attempt resuscitation or CPR is only applies for the CPR. All other appropriate treatment and care for the for that certain person should still continue. So what is the TEP form? So the TEP form describes an increasing levels of interventions to plan and focus on what intervention of a certain patient will, whether a certain patient will or will not receive a certain intervention. A senior clinician, that means an ST3 plus, with a knowledge of the patient and the history, preferably after discussion with the family and the next of kin, is best positioned to designate and appropriately seal the care of a certain patient. Very often, no sealing of treatment is documented, leading to difficult, unnecessary investigations and interventions for a certain patient. More importantly, it leaves difficult decisions for out-of-hour doctors who are not aware of that patient and has never been in contact with him or his family in situations where there is no clear guidance. So what is the aim of a treatment escalation plan? It's basically to facilitate identifiable shared decision-making with people who are at risk of acute deterioration and the documentation of such discussions and decisions, and to have a clear identifiable treatment escalation plan in the notes signed by a consultant within 24 hours of admission in patients with DNA CPR. To be very honest, I know I've mentioned here with patient with DNA CPR, but actually the national guidelines now is that everybody should have a TEP form completed by 24 hours and signed by the consultant, as long as he is for admission to the hospital. So there are 8 main domains that should be included in every documentation, which is TEP form, which is the discussion with the next of kin, antibiotic therapy appropriate, whether it is appropriate or not for the patient, assisted feeding, whether it's appropriate or not. And by assisted feeding, we mean the NG tube insertion and the parenteral feeding, intravenous fluids, inotropes, NIV, renal replacement therapy, meaning basically hemofiltration or hemodialysis, ITU escalation, and starting the end of life care, whether it's appropriate for that patient or not. For doctors who are not working at the NHS, the end of life is a term that means that this patient will not likely benefit from any sort of intervention. Will not likely benefit from any simple treatment, including antibiotics and IV fluids. And then the way we treat him is literally we just keep him comfortable. And it's usually a decision is either to be taken by seniors and also to be taken after discussion with the patient's next of kin. So the discussion with various steering groups. So bear in mind that a lot of patients will not be competent. They will have low GCS, they might be confused or demented, and you don't know much about this certain patient. So the way you know is through the other steering groups, including the ambulance services, who is going to pick the patient from whether the residential care home or his family home. So he will know a little bit more about that patient than obviously you. The palliative care are very helpful, and they're usually available in most of the hospitals that you can contact at any time. Medical consultants, obviously, if you're not sure, always escalate, and then representative from the primary care. If you are still within the working hours, then you can contact the GP or the district nurses, or for example, if patients with heart failure, then you can call the heart failure nurse. Patient in the community or NHS workers in the community that are more familiar of this certain patient. His functional status before coming into the hospital, what he's able or not capable of doing. So there are different forms of treatment escalation plan. You can see here one of the forms, which is a handwritten form, it's a bit difficult because sometimes it's a bit tricky to read other people's handwriting, and there are a lot to fill, as you can see here in this form, which obviously one thing we're very lack of in the acute setting is time. So it does take a lot of time to fill this form, but yet some of the trusts still do have the pre-handwriting forms. The forms are in usually two different forms. So it can be part of the clerking performer, or it can be a separate sheet that you can attach to the patient's folder. The next slide, you can see the other types, which is the easier types of the treatment escalation plan. If you can go to the next slide, please. Which is the tick boxes form. There's a very important thing, obviously this is as easy as you can see. The most important thing is if the patient is for full escalation, if you tick yes here, or if there was boxes, you just tick the box for full escalation, the patient would immediately be entitled to have all these interventions mentioned, NIV, Optiflow, vasopressors, renal replacement, and so. Yet, if you tick no for the full escalation, that means the patient has a DNA CPR form. So you should make sure that you fill a DNA CPR form once you tick no for the full escalation part. Then the patient might or might not be entitled of a limited escalation, which is NIV, Optiflow, vasopressors, renal replacement, and ITU escalation. Okay, having a DNA CPR does not mean that you should not be entitled of having any of those interventions mentioned. If you move to the next slide. The very important notes here are, please check if the patient has a DNAR completed in the community. So if the patient has a DNAR at the community and then he was not conscious enough to let you know his wishes, you didn't have the chance to speak to the next of kin or anybody else, and you've decided that this patient is for full escalation, there could be some legal issues here. So please always make sure whether this patient has a DNA or completed at the community or not. Please check if the patient has a TEP form completed at the community or from a recent hospital admission. Given that the circumstances did not change, you can find sometimes in certain circumstances, especially during the COVID time, the patient would have a TEP form in his previous admissions that says he's not for escalation, or he's like, even for the limited escalations, he should be not entitled for this or that. And then whenever he's readmitted again, some of these circumstances changes. The patient's condition generally improves, and you feel that he could benefit from this escalation. So TEP form can be reversed or rewritten at any point of the patient's care. If the patient is a resident of a care home or a nursing home, they often have a escalation plan in their notes from the home. Make sure the next of kin is involved at during the patient's treatment. Always check if the next of kin has the power of attorney. So sometimes a lot of patients would have one of their cousins or his son or wife or whatever, then they would come over and say, no, we would like our father to be kept comfortable, and so, but they don't actually have the power of attorney, and other members could actually be unhappy with that decisions if you do not check, and it could be some legalities in this. I'm not really sure what sort of legalities, but I'm sure that the one thing I'm sure about is that we have always to check if the next of kin we're speaking to has the power of attorney or not. If in doubt, always escalate either to the consultant or the ITU team or both. All patients admitted to the hospital must have a TEP form as per the national guidelines, as long as they are to be admitted. Okay, if we move to the next slide, please. Okay, what common mistakes we can do? Everybody can do mistakes. So what are the mistakes that we can do? Okay. Okay, so when we've done an audit about the treatment escalation forms at the hospital where I'm working, we've noted that there are a lot of discrepancies, or sometimes there's some discrepancies in documentations. So some patients would have a DNA CPR form already completed, but they are still for escalation, which can cause a lot of confusions to doctors or member of the teams that are working, especially in the out of hours. And there will be, and this can affect the management of the patient. So please make sure that both of them are filled appropriately. The specific section of the NIV and RT are not completed in many of the forms. We found that they're not completed in many of the forms, to be honest, because these two decisions are a bit of complex decisions. So sometimes you're not really sure, and sometimes you'll find even the consultants are not really sure about it. So don't be afraid to escalate. And if you are in doubt, you can leave it until the consultant is here. The most important thing is make sure it is completed by 24 hours. Okay. Obviously, much room for ambiguity. And then some sections were to be found in the proforma, but not in the treatment escalation plan. Example for that, the patient could be admitted, this is the 5th day of the admission, and then we've decided the patient is for end of life. Yet the TEP form is mentioning that he's still for full escalation. So we have to, if the condition of the patients have changed, please make sure you revise or rewrite a TEP form for the patient, okay? Whether to he improved or he deteriorated, just make sure the TEP form is suitable for the patient's medical condition at the time, at every time. And then the patients who are medically fit for discharge on the wards are no longer considered for TEP form, which is not appropriate, because obviously, anyone who works in the NHS would notice that patient could be medically fit for discharge and they would still be in the hospital for another like 2, 3, 4 months, is waiting for social circumstances to improve, like finding a nursing home or a placement bed, or like being fit for reactor, any other reason. Everybody should have a valid TEP form as long as they are in the hospital. Okay, so thank you so much for allowing me or giving me this chance to present. Thank you, such a group, and these are my resources or references. If you have any questions, I'll be happy to answer. All right. Thank you so much. Have a good day. And best of luck for everyone.
Sorry, I thought you can hear me, but my mic was mute. One of the participants is asking about the cardiology training for pediatric. Do they have to start from the beginning, or there is separate cardiology training? I'm not entirely sure about that. I don't know much about pediatric training. If anyone has an answer, please shout out.
Unfortunately, I'm only aware of the cardiology training for adults, but not for the pediatrics. We'll be grateful if anyone could help us regarding this matter, please, from our pediatric colleagues, pediatric registrar colleagues.
Do we have any pediatrician with us? I don't think so. We are so sorry. We couldn't find an answer. I don't think there is any pediatrician with us, but if we find any answer, we'll make you aware.
Okay, can I start my presentation or? Hello, Marwa.
Yes, you can, sure. Go ahead.
Okay, sorry. Okay, my name is Maida Muhammad. I am one of the acute medical doctor in Bedford Hospital. I will gonna talk about the acute medicine scoring and commitment. But the first thing before starting anything, we need to know about, we have an overview about this specialty as acute medicine. First question we need to ask ourselves as a part of from this specialty, why we choose acute medicine? What is the benefit about choosing the acute medicine as your specialty? It's make the difference. Making the difference because you are the first defense line. You supply the patient. You will manage the acute illness of this patient. So you make a lot of difference in the life of the individuals. Flexibility and part-time working, high income early in your career, and for the also you can work anywhere in the world if you like to work outside the UK. And for those people decide to stay in the UK, working in this specialty providing you with excellent pension scheme. There is also good holiday entitlement and the NHS discount in shopping and restaurants. We can count this as a part of benefit. Then the other thing that what the aim of acute medicine trainee, the characteristic of the acute medicine trainee, he must be a good team player, and he have show a good clinical leadership because he will be leader for multidisciplinary team. He has the ability of changing management and solving problem and lateral thinking. Also, you will face a variety of clinical scenarios. That's why you need to be very flexible and adaptable. In order to be clear, you need an excellent communication skill, both spoken and written part. And the most important thing that you can work under pressure because the work environment change day to day, and it is very dynamic area of specialty, and you will work with different kind of, you will meet different kind of people, different kind of clinical scenario, different kind of people from many ages with different clinical issues. The very important thing is that you need to be calm with emotional resilience. This is the trainee in the characteristic. Other thing, we need to talk about the life in acute medicine. Okay, we can go to the other, the other one. Life in acute medicine. You need to prepare yourself that the acute unit always very busy. You will treat patient of, as we said, of different scenario, and this is need you that you have a lot collateral thinking, and you will interact with numerous colleagues, including consultant, emergency department staff, clinical care, and other medical specialty. During your trainee in this specialty, you need to perform in regularly in day-to-day basis, lumbar puncture, paracentesis, and pleural aspiration. So if you have, if you performed already this type of you have experience in those things, you can apply, you can put it in your application, and this show also a commitment to this specialty. At the end of your training, you gain experience in managing, we can move to the other slide, please. So what you gain when you are in the end of your training in this manage acute medical illness, you can manage patients, a medical patient as inpatient patient, as inpatient situation. You can develop new pathway. You can provide the leadership mainly in the acute unit itself, and you develop multi-professional system and experience in critical care unit as well. Working as acute medical doctor, the workplace, unfortunate, will be in the hospital. It is hospital-based specialty. You can't work anywhere. No private clinics, nothing. So prepare yourself. If you choose this specialty, you will be in the hospital always. During your training, we can move to the other slide. The other one. Okay. During your training, you will the training, you will spend the time in AMU, and you have attachment as well in the respiratory medicine, in the cardio and care of elderly. Some regions can give attachment to GIT, to the neuro and stroke as well. Okay, after we have this overview regarding this specialty and how you live in this specialty, we need to know about how to prepare a commitment, how to show a commitment to this specialty. As my colleagues, all of them, they are expressed a lot of things regarding this, how to prepare your application. I just will add some examples here to show this commitment. Can we go to the commitment part, please? The other slide. Okay. What may be count as a commitment to the specialty? I think these commitments can be relevant to most of the specialties, and in specific, I will talk about the acute medicine. If we start the relevant clinical exposure, during your application, you need to show that you are have a good clinical exposure to the specialty, to the acute medicine. If you are in the medical school, you have special study models related to the specialty. It will be benefit, and the good things in the acute medicine that even if you show other part of medicine, it will account. Second thing, in the postgraduate experience, you need to choose from the clinical rota that if you have any clinical rota related to the acute medicine, you need to talk about it in your application further and expand this part, so you show the commitment to the specialty. And if you have a rota in respiratory, cardio, geriatric, most of the people have this rota. So you need to show this rota and talk about it in your application. So it will stand, let your application stand out. And if you have any non-training post like clinical fellow, even locum work, all this can be accounted. If you have shadowing, an on-call registrar in this specialty, it will be very fine as well. If you have signed practical skills that if you have doing paracentesis, lumbar puncture at this chest drain, if you have this signed already in your portfolio, you can also show that in your application. So this will increase your chance and show a commitment to the specialty. Also, if you attend clinical sessions and MDTs regarding the specialty, this is also will account a lot, and this will show will be relevant in the clinical exposure. Sometimes someone have no rota on as F1 or F2, so he can organize tested week. I can give some example how to organize tester weeks. You can plan few weeks or months in advance, not like a full week, even days over the weeks, it will be okay. Take a study leave at that time and organize relevant experience. And you can think collaterally and organize visit or contact local ambulance services and schedule them, ask them to schedule their crew and spend that day with them. So also this can give you an experience, and this can be showed in your application as well. Regarding research, if you have a project in the medical school, it's gonna count. And after your postgraduate, you if attending or taking active part in a non-mandatory specialty specific journal club, this is can be very helpful. If you authorize a paper, if you help in a specialty trial or submitting ideas for clinical trial for a specialty specific group, also this can be very helpful. If you want the highest degree, you need to you have a postgraduate research degree. This will be the highest degree in the specialty. Also, don't forget if you awarded prize, as my colleagues previously, they are talking about it. And I think here I can't add anything more. If you attend a conference or events as a delegate or as a presenter, you just also can show this in your application, and this will be very helpful. And you need to show this presentation if it is a local presentation, it is a regional or national presentation. If you have any evidence regarding this, will be very helpful and will show a commitment to the specialty. Okay, also we need to show a self-directed training in acute medicine by attending, if you attend a webinar or e-learning models, this will be very great. If you have any certificate or diploma in the acute medicine, this will be accounted. Or if you attend the non-compulsory courses like in the specialty society or Royal College, this is also can push you forward and stand your application more. And sometimes some people have part 1 specialty exam. It's account also, it will be okay. The other thing in teaching training, I will give you some examples as well, how to do this teaching training. You can arrange a training session with the medical students. So this will be regular sessions, and this will be accounted in your specialty. Medical student, nurses, other staffs, it will be helpful. The courses, teach the teacher, train the trainer courses, can give you 1 degree. And sometimes if you can approach to a local school and make short talk regarding any topic in your specialty, raise awareness of hand hygiene, anything, this is can inspire to inspire the students. This is also can be self-directed training. You can show that. Getting associated with relevant societies, also this can count in your application. Sometimes in the specialty, I think this is not only in the acute medicine, most of the specialties have charity. If you just get involved in the charity of the acute medicine, as I am talking currently, you design anything. If you suggest community project for a community project to raise the awareness of people regarding any specific thing, if you do this also, this will be very helpful, and this let your application stand out. I think also we need to talk about the leadership and audits, but this already talking about Marwa and all colleagues talking about it in a very good way, so nothing to add in this thing. Thank you for listening, and I hope for all to have a good luck with this, with all your life and this application. Thank you. Any question if you have? Hello? Any question?
I don't think we have any questions on the chat box, and no one is raising hand or saying anything. You can unmute yourself.
No question in the chat. Okay.
Okay. Right. So this is bring us to the end of today meeting of the first day of the tester days, and we're gonna see you all tomorrow. We'll announce the start time in the Facebook page. Hope to see you all tomorrow. Thanks, bye.